Bear with me. I'm just trying to get it to switch screens real quick. 1 second. Is that the correct screen now?
Yes.
Okay, perfect. All right, so my name is Kristin Beinschroth. A lot of people know me as Professor B. I'm a visiting professor at California Baptist University. I'm also an adjunct faculty at Chaffey College. Just like Sadie was talking about, this is one of the lectures that I just did at a CERT at the Vegas conference. So I like to study forensic radiology. This is part 2 because I do this lecture pretty often, at least once a year. And I try to update it. I do want to just be pretty clear about, I don't necessarily work in forensic radiology. I'm really lucky to do kind of the meta-analysis or the aggregate data where I look at all the journal articles and kind of compile it into a summary. So I put my email address in the chat. So if you're interested in learning more about it, or if you just have any questions that don't get addressed tonight, feel free to email me. It's also in the PowerPoint, and I can make that available to you as well. So just a disclosure, I'm not an employee or a stakeholder of any of the organizations that I may talk about in this presentation, so there's no conflict of interest. I do want to give trigger warnings because as much as I try to leave out the very gory things, there are pictures of death, autopsies, human remains, trauma, and assault, just because the nature of the presentation topic. So our objectives, we're going to describe the current state of the field of forensic radiology and kind of how it has evolved. So we'll talk a little bit about the history of how it came to be and why it's really gaining some traction these days. We're also going to talk about interprofessional aspects because you will work with different professions than you normally would as a regular kind of medical imaging technologist. So we'll talk about those a little bit. We're really going to focus on CT and MRI. CT is the focus of forensic radiology and what gives us the most value. MRI also has a little bit of value, but there is problems with the lack of water in tissues after death. So there's a little limitations there. We're going to differentiate between what is a conventional autopsy and what is a virtual autopsy, also called a virtopsy. And then we're going to list the benefits that radiology lends to anthropology, law enforcement, and the justice system. So in 2009, the National Academy of Sciences published an article that was called Strengthening Forensic Science in the United States, A Path Forward. And it really questioned the scientific basis for virtually every forensic discipline used for criminal conviction. So where we used to use hair analysis, fiber analysis, fingerprint analysis, there's a lot of those things that have actually been debunked in recent years. DNA analysis was the only discipline that really could not be scrutinized. And we couldn't say that there was really any area for it to be invalid. So straight from the article, they said that no forensic method has been rigorously shown to have the capacity to consistently and with a high degree of certainty demonstrate a connection between evidence and a specific individual or source. So some of our other methodologies that we use to try to solve cases or try to solve crimes are a little wishy-washy, and they're what we call a soft science. So it's not so black and white, there's lots of gray areas. And unfortunately, when we're talking about convicting somebody of something like murder, we really want to rely on the black and white and not rely so much on the gray. So these are the National Registry of Exonerations just from 2020, which is the most recent data. There were 2,684 exonerations since 1989. That means that 2,684 people were convicted of crimes and paid their debt to society who were not necessarily guilty of those crimes. That resulted in more than 24,150 years lost of their life. And that's years lost away from their family. That's years lost working towards a career. That's years lost in contributing to society. So you can see that from 2017 to 2019, we actually had a huge drop in the exonerations. And a lot of that has to do with the fact that we're now relying on these hard sciences, the black and white, the DNA, and less on the soft sciences. All right, so these are the percent of exonerations by the contributing factor. So we have a mistaken witness ID. So it used to be that personal testimony was kind of like gold or platinum in court. And what we found is that personal memories can actually be changed using methods of coercion. So we're starting to rely on those a little bit less. Perjury or false accusation makes up a big part of why people were wrongly convicted. False confessions, which if you watch Netflix, there's plenty of stories on false confessions, but how people, again, were kind of coerced into saying things that they didn't necessarily mean. The next one is false or misleading forensic evidence. So that would be kind of what we're focusing on today. So fiber analysis, fabric analysis, hair analysis. And then the next one is official misconduct. So the ones that we're going to focus on today are mistaken witness ID and false or misleading forensic evidence. Both of those are more like soft language. So we're going to talk about how we can replace those percentages of exonerations or reduce those percentages of exonerations with something a little bit more concrete. So on the left, we have things that historically were considered science, and now we've found that they aren't as concrete as we'd like them to be, and they're now referred to as junk science. So blood spatter analysis. So apologies to anybody who is a Dexter fan. I did like the beginning of Dexter. I can't watch it anymore. I'm too involved in it. But blood spatter analysis is very difficult to recreate exactly the same scenario. If you've ever seen The Staircase on Netflix, they talk a lot about blood spatter analysis and how it just did not add up with the actual evidence. And there was a wrongful conviction in that case. Fiber analysis. So fiber analysis, there are fibers in our carpet, there are fibers on our clothing, there are fibers that float in the wind, really light fibers, heavy fibers. And what we would do is we would say, well, if the fibers from this carpet are found on the corpse, then we can say that this person was most likely in that area. But a lot of carpet fibers look really similar, and a lot of polyester fibers look really similar, and cotton. We used to look at hair microscopy, and we wouldn't look at it in the sense of the DNA that can be found in our hair follicles. We would look at just the hair itself. And as we know from working in the medical field and from studying anatomy and physiology, our hair is all dead. Everything that we see is dead hair, and it's very easy to manipulate it. It's a very porous subject, so it can absorb things. This is why we're able to change our hair color. So it was really difficult to say that this hair came from this person without actually coding the DNA in it. Bite mark comparisons. This was actually used in the Ted Bundy case back in the 1970s. There was a victim that was found with bite marks on her body. And so they took dental impressions of his teeth and then tried to recreate those bite marks using basically like a phantom, like we would use in X-ray. And we found that those were also not very reliable because many of our teeth can look really similar if we're not looking at actual cavities and fillings and implants. Also, firearm tool mark analysis. So it used to be that we would believe that every single bullet that got discharged from a firearm would match that bullet almost like would match that firearm almost like a fingerprint. So there were grooves on the inside of the barrel of the firearm, and those grooves would be imprinted on the bullet when it was fired. We found that it's actually easy to recreate what it would look like it came from one firearm, and it actually came from another that was really similar. So that's also kind of being pushed out the door. Shoe print comparisons, because if you look at, if I were to have everybody raise their hand who wore a size 7.5 shoe and everybody that owned a pair of Vans tennis shoes, we would quickly have a very big pool of people that might be a suspect. And so it wasn't very specific. We need things that are very specific and very reliable. So what we have now shifted to is the things in the right-hand column, which are current forensic science. One, we use human identification. This is particularly investigations of mass disasters and decomposed bodies. And I'm actually going to talk about how during 9/11, we used radiography to do mass ID of the people that perished. And then evaluation and documentation of injury or cause of death. That used to be done by conventional autopsy. And now it's more likely to be done by virtual autopsy. Criminal and civil litigation, whether it was fatal or non-fatal, usually most of that gets worked out in the justice system. Bullet fragments. So bullet fragments are more specific than firearm tool mark analysis, because we can take bullet fragments from multiple portions, put them back together and see if they fit. And it's kind of like a puzzle. And so it's pretty easy to say, yes, they came from the same bullet or they didn't. Administrative proceedings, education, research, and administration. So again, you can see that the things on the right are more specific, more sensitive. They give us more true positives and less false positives, more true negatives and less false negatives. So where are we today? Forensic radiology is a subspecialty dedicated to ante-mortem and post-mortem imaging. So those of you at Loma Linda, you probably know that there is a pediatric forensics unit at the hospital. And most places where if there's any suspected non-accidental trauma of a child, which we used to call child abuse, now we call non-accidental trauma, they always got referred to Loma Linda. So I worked at an urgent care in the area, and if we ever had suspicion, we immediately sent them to Loma Linda, and that was ante-mortem imaging. So just because we suspected any type of criminal nature, then they would go to the forensics department. They do the detection and documentation of pathologies. So again, these are usually for medical legal purposes. If somebody is having an autopsy post-mortem, it's usually because we're concerned about cause of death or we're trying to figure out the cause of death. So not everybody gets an autopsy. That's usually based on criminal circumstances or on the family's, them asking for it to happen, so their request. This is increasingly, forensic radiology is increasingly used in conjunction with conventional autopsy. And so the way we do that is we basically do a CAT scan. We do our multiplanar reconstructions, our 3D rendering, our volume rendering, and then we're able to put it into basically like an app in an iPad and do an autopsy without ever actually cutting open the patient. So this is really valuable for families that may want to know what happened to their loved one, but are not comfortable with the idea of their loved one being cut open and kind of having their organs examined after death. You know, a lot of people believe that there is a soul in the physical body and they don't necessarily want to interrupt that process. And so virtual autopsy gives a much less invasive opportunity to kind of view what's going on without necessarily having to make physical cuts. So radiography has really been a staple of forensic investigations. It was first used in 1896, which was only a year after Rankin discovered X-rays, and those radiographs were admitted as evidence for the first time in a malpractice lawsuit. So because there has been so much evolution since then, it has changed. We're still a little hesitant to really induct it into evidence and use it on a regular basis, but it is going that direction. So we've been slow to adopt CT and MRI into forensics. Part of that is we have a ton of regulation in the US, so it really takes a long time to get things approved by the FDA, and then putting it into practice is a whole nother ballpark. So in some countries, it's actually pretty widely used, but in the US, it's still kind of gaining some traction. So in response to forensic radiography starting to take hold, in 2007, the ASRT formed the Forensic Radiography Task Force. And the goals of that task force were to gain recognition for forensic radiography in the US, to encourage development of CEUs, like this presentation could be used for CEUs in the right place. And then we collaborated with the UK, who was doing really well with making a place for forensic radiography. So after about 3 years working, that task force was able to publish the State of Forensic Radiography in the United States in 2010. And this really established the footing needed to formally establish programs. So, and to this day, there's really not a ton of forensic radiography programs, but there is this framework out there so that if a program is ready to begin, we have really good outline of how we do it, what we do, and in what time period. So now I want to talk a little bit about the interprofessional workspace of forensic radiology. As a regular radiologic technologist or any type of medical imaging technologist, you're primarily going to be working with physicians, physician extenders like PAs and RAs, nurses, EKG techs, pretty much all of those kind of hospital professions. When you're in forensic radiology, you're working very much outside of the hospital, and you're working with different types of professions. The first one is anthropology. And actually, as a student at CSUN, which is where I went, UCLA does a lot of research. And when I was there, there was actually a morning that they invited students to come see a scan of a mummy. So we were able to see it. And usually those scans are a lot of people in the room. You kind of have your curator or your historian from the museum. You have security, you have a lot of VIPs from the hospital, you have the technologists, you have radiologists, you have pathologists. There's a lot of people in the room, but it's a really good experience to kind of see how that process works. So anthropology, we're looking at mummified remains. So a lot of, you can see here the Queen Nefertari. There's a video here where we actually scanned her in Kansas City. So it's a lot less invasive than traditional autopsy because again, there's a lot of ideas around hauntings and ideas around letting the souls escape from tombs. And so going into the pyramids, that's why the mummy exists. And that's why all those movies exist, because there's so much around it saying that we shouldn't, maybe it's cursed that we don't do that. So to do an invasive autopsy, not only would we be desecrating remains, but we would be desecrating history as it lies. So by doing a virtual autopsy, we're able to preserve the contents inside and still be able to study the remains. So anthropology, in the field of anthropology, you may work with historians, curators, and then simply cardiologists. So I'm going to quickly play this video and hopefully it works and hopefully you can hear it.
Inside St. Luke's Mid-America Heart Institute, doctors are using a CT scanner to look back in time.
She was considered very important.
These mummified remains, all that's left of one of the most famous queens of ancient Egypt, Queen Nefertari, the first wife of the great pharaoh Ramses II, known for her beauty and the power she wielded behind the scenes. She ruled alongside the pharaoh from 1279 to her death around 1255 BC.
Ramses adored her. He called her the one for whom the sun shines.
She's here in Kansas City on loan from the Italian Museo Egizio in Turin for an exhibition at the Nelson Atkins Museum of Art.
And we're going to look at life in Egypt. It's not about death. It's about how people lived 3,000 years ago.
These scans
This is the volume rendered reconstruction of the legs.
will be analyzed by cardiologist and internationally recognized mummy research expert, Dr. Randall Thompson. His team will try to determine whether or not Nefertari suffered from heart disease thousands of centuries ago.
One of the main things we're looking for is whether there's any arterial disease in the leg. It's amazing that if there's calcium in the arteries, it lays down, and 3,000 years later, you can still see it with the CT scanner.
With hopes that information could lead to a better understanding of the ancient Egyptian queen and her people. In Kansas City, Matt Evans, KBC 9.
So you're able to see not only kind of maybe the reason that person died if you have like a full remains, but you're also able to see a little bit about how they lived their lives. And then we can really study, life back in that time period. So moving on to the next profession that you may come into contact with are criminologists. So I have a picture of Paul Holes here. If you listen to podcasts or you're into true crime, Paul Holes is the criminologist who was responsible for catching the Golden State Killer decades after he was an active serial killer. He's now a podcast host and he just published a book. But criminologists study the nature and causes of crime, criminal justice, and the justice process. So in skeletal remains, so if you look at this image on the bottom left, we can take skeletal remains and then we can do a CT scan on it. And instead of doing like artist rendering of a picture, we can basically do a 3D rendering of the entire body part. So this happened. John List is also a serial killer who was caught decades after he was active. So he actually killed his entire family over money. And then decades later, they did an artist rendering of him, and they actually did a bronze bust. So the picture wasn't enough to kind of make him recognizable, but they did a bronze bust just based on what they knew about him, years earlier. And his neighbors saw the bronze bust on TV, on the news, and reported him. And then they did DNA testing and they linked him to it. So that's one of the things that we can do, but instead of making a bronze bust, we can now do it with 3D printing or with a CT volume rendering, where we can view the images on a 2D screen, but we really make it look like 3D using shading and different rendering to go through the tissues. So that's one of the things that we can do. We can also evaluate if something is accidental versus non-accidental trauma. So non-accidental trauma is the new term for what we used to call abuse. So we can look at maybe a cause of death or just an injury and then assess, is this likely to have been accidental, or was this most likely caused by like an outside force? We can evaluate the point of impact, the direction of impact, and then the shape of the object or the weapon. So we can say, using 3D CT scans, we can see that the impact is going from the back to the front. So that person was likely attacked from behind, and so they didn't see it coming. Other than that, medical imaging is part of the interprofessional workspace. For the most part, it's radiography and CT. In CT, we do MD-CT, which is full body multiplanar, a study using multiple detectors. And we use some post-processing techniques like 3D rendering, maximum intensity projections, which basically pulls just the vessels out, and we're able to isolate and view the vessels without all of the anatomy around it. Very similar to what we do like digital subtraction angiography. We also use shaded surface display. Shaded surface display lets us see the outside of it, and the 3D rendering lets us see all the layers of the inside. We do use MRI and bone densitometry, but those are less specific and less sensitive than radiography and CT are, so they're usually only used as kind of backup method. So you can see here on the top left image, there's mummified remains. And then what we did is just a quick scout of a CT, and we're able to actually see what's inside. This is really helpful in when we are evaluating if somebody was pediatric when they passed, or if they were an adult. We can look at growth plates, we can look at the size of their bones. Here's an example of CT with multiplanar reimaging or multiplanar reconstruction imaging on the bottom. You can see that the skull is actually empty. So the brain is already decomposed here. So this gray area is the brain, and all of that black area is just air. So we have our sagittal plane, we have our coronal plane. This is our surface rendering on part C. So you can actually see kind of the skin on the hand. And then D, this would also be a coronal plane of the entire thing. The bottom right images of the child kind of in the fetal position, this is shaded surface display. So it lets us see the outside of the bones in a way that we can view them without necessarily touching them. So this is where teleradiology comes in as well. We can view these at remote sites, have a bunch of different people kind of on a Zoom conference call just like this, and we can be viewing the remains all together. So we get to have that interprofessional workspace, even though we're in different geographical regions. So the professionals for medical imaging that you would work with would be technologists, also radiologists, but the radiologists are usually specifically trained in forensic radiology. Forensic radiologists need to not only have a comprehensive knowledge of anatomy and physiology in living humans, but also decomposition and how that anatomy and physiology changes after decomp. So they really need, they also need to study different patterns of injuries. So it's really kind of like a criminologist and a radiologist at the same time. And then the next one would be pathology. So a pathologist or a pathologist assistant. This is Nicole Angemi. She became an Instagram influencer secondary to her day job, which is a pathologist assistant. It's basically a PA for somebody who does autopsies. And she is now a published author as well after having been on Instagram. But in pathology, you may work with laboratory technicians. So histotechnology, as you may remember, is the study of tissues, and cytotechnology is the study of cells. So there are two different technicians that do two different types of jobs that work together. You will work with pathologist and pathologist assistant, and then a coroner, who is usually a pathologist as well. Next, you have the justice system, so RBG, RIP. Lawyers need professional experts to come and testify in court. So as you are a technologist, especially if you get really active in the field and you start to do more publications or more speaking, then you may get approached by lawyers to come and sit and be a forensic expert or a professional expert in radiology. We found that blood spatter and fiber analysis are pretty much outdated and have really become junk science. So DNA and the medical evidence that we can provide are really taking precedence in the actual courtroom. Okay, so now that we talked about the interprofessional space, now I want to talk about how do you really perform this job. So multi-detector CT provides full body multiplanar studies. So we're able to take axial images, kind of slicing a body like a loaf of bread. Then we're able to put all those slices back together and then just kind of turn it on its side and view it in different planes. So we can do sagittal, we can do coronal, we can keep our axial scans, we can do paraxial or transaxial, where we kind of go in at an angle to better match a piece of anatomy like the spine. This can be enhanced by advanced post-processing. So just looking at it in those new reformats, those 3D rendering, volume rendering. And this really plays a key role in the detection of the bone structure in trauma or internal hemorrhage in patients that have penetrating wounds. So this allows the identification of the entity that applied the force or of the wound track in which that entity passed through the tissue. We can look at the extension of it, how far it passed through, the direction, and then other legal aspects of it. So if you look in this image on the top right, we can see that there's actually a knife embedded in the chest. This is a surface rendering where it kind of looks like the skin. And then to the right of that, we look at volume rendering. We basically peel back the layers of tissue that we don't want to see to evaluate the layers of tissue that we do want to see a little bit better. So that's done through a 3D rendering. So in this one, you can see the aortic arch coming up and over, and you can see that the knife does not pass all the way into that aortic arch. So kind of right up here, it's basically just going just past the sternum into the mediastinum. Here are some multiplanar reformats. The axial is on the bottom left, and then the coronal is on the bottom right. So we can view not only, this is the path of the bullet. So based on where the bullet fragments are closer to the skin and where the bone fragments are closer to the skin, we can ascertain that this person was most likely shot from behind and then it exited through the front. Sometimes exit wounds and entry wounds look very similar if there's not a huge change in the tissues inside that would cause it to change its pathway. So if we were to just look on the outside, it wouldn't necessarily give as much information. But on this one, you can see towards the left, these little bullet fragments that are extending anterior to the vertebrae. That gives us the impression that it traveled, and usually when it exits is when the little burst happens. When it enters, there's no little burst. So you can see back here on the bottom right, the posterior patient's left, there's not a whole lot of bone fragments there. And then this is the coronal plane, so you can see the vertebrae and how it was actually able to penetrate that. So unenhanced post-mortem CT is called PMCT. This just means that we're not giving the patient contrast, that IV iodinated contrast. This is usually done before autopsy when all of the internal organs are still preserved, because autopsy irreversibly changes the anatomical structures. Once you cut it open, once you sew it back, that patient isn't able to heal anymore because they are not alive anymore. So it really leads to you lose the integrity of the evidence. Remember that anytime you kind of touch something at a crime scene or you manipulate it, you have the ability to lose some information. So when we don't give contrast, there's quite a few limitations in the overall study of the vascular system and also the soft tissue system. So the same reasons why we give contrast in a living patient would be the same as in a non-living patient. It highlights organs that have inherently low contrast. By giving something that absorbs photons, it creates more photoelectric absorption, and so it increases the tissue contrast. It makes it higher contrast. So because of those limitations, we now said, well, how can we put contrast in those vessels to better highlight the area? And that led to multi-phase post-mortem CTAs, or CT angiography. So multi-phase means that we can do a venous phase, an arterial phase, we might do a delay phase, or even a perfusion phase where we're looking at how the oxygen perfuses into tissues. We can link the regular native non-contrast scan and the 3 angiographic scans, arterial, venous, and then dynamic when it's in a little bit of both. And it's similar to like a live CTA. The only problem is the patient is not able to circulate the contrast via their cardiovascular system. So we have to do that part a little bit different. So what we use is a different type of iodinated contrast that is actually a mix of paraffin oil and a very oily contrast. So remember that when we're living, we're 80% water. As my program director called us, we were big nitrogen bags of water walking around because we're so much water in our system. And what happens is when you decompose, all of that water gets eliminated. And so you are now no longer kind of a water-based paint, you're an oil-based paint. And so in order for your body to basically accept the contrast and allow it to perfuse into the tissues we want, the way we want it to, we have to use an oil-based contrast so it's compatible. We also have to use a power injector. We want to inject really quickly. So remember, if you've had a CT class, or if you're in my intro to CT class right now, the CTA, we have to inject at 5 milliliters per second in order to get a really strong bolus of highly photon absorbing iodine contrast. If we inject it too slow, it kind of gets diluted really quickly and it's not as bright and obvious on images. So we use a power injector, and this really helps mimic perfusion in a living body. Nowadays, this is pretty routinely used, and it actually has shown better results than a conventional autopsy, especially in detecting the source of hemorrhage and coronary occlusions. So you can see these are our post-mortem CT images, the kind of green area of vessels. The reason you can even see these vessels is because we're using our maximum intensity projection. So all the things that would normally show up white on an image, we're able to basically tell our very sophisticated computer software programs to take everything out that's not white, and then only the white things show up on the images, so the bones and the vessels filled with contrast. What we do is, because we can't start a peripheral IV because the veins aren't kind of plumped up enough for us to get access, we actually get femoral access. The coroner will get femoral access for us, and they will hook up the injector to the patient like that. So here's another, this is kind of a picture of what it might look like if you're doing postmortem CT angiography. You've got your power injector here. Here is the tubing that is hooked up to the patient. Your patient is wrapped in a body bag. And then these are the tubes that we're going to, so basically the same way that they embalm a patient, we're just no longer going to put the embalming fluid in, we're going to put contrast in. And then later they'll go back and embalm, but they already have that venous and arterial access. So you can see the little red one is signifying an artery and the blue one is signifying a vein. So they will inject into different ones at different times and take pictures to get pictures in all of it. So this particular study out of the Institute of Forensic Medicine in Zurich, Switzerland in 2014 found that the formation of postmortem clotting appears predominantly in the right side of the heart, pulmonary trunk, and the great vessels. So the diagnosis of potential pulmonary thromboembolism, or a clot in the pulmonary artery, has to be based on the combination of both the radiologic findings and the histopathologic findings. So the postmortem CT, as well as going in and kind of biopsying that tissue to take a look at it, or doing the conventional autopsy. Findings of the clotted material. So this material can be easily obtained with an image-guided biopsy. So again, we don't necessarily have to do a full autopsy. We can just do a biopsy and a postmortem CT and get really good answers. This is another case study. So here we've got, this is our axial volume rendered, showing a little aneurysm right here where the arrow is on the top left. Then, so this is from our CT scan. We can also see it when we just remove and just look at the vessels, and then we can see how it's affecting the brain as well. This is a really good one on the right, where they had a trauma to the neck, and we were concerned that this broken mandible here might have severed the carotid artery and led to a hemorrhage. So on the imaging, it shows that there is an occlusion right here at the artery. And then at dissection, we were able to see this kind of large area that looks like a teardrop. That actually was a dissected carotid. So either the mandible or the traumatic object did cause a break in the carotid artery. So that's, again, a picture of how we use CT imaging as well as that histopathologic finding. Here's another one where we actually found a hole in the heart. So this is our kind of our heart scan. This looks like a lot, or it looks a lot like a CTA of the chest, where we just take the heart and look for like coronary vessels. We might be doing cardiac scoring as a heart screening. The axial image, they were stabbed in the chest. So the axial image, we inject contrast. We can see contrast filling up in the lung, which we wouldn't expect. We can see contrast here in the aorta, which we would expect. And then we see contrast leaking into and out of the heart. So that confirmed that there was some type of suture in the heart. And then here at autopsy, we see that there's a huge hole in the heart. So that patient actually bled out into the pericardial space, which created pressure on the heart, no longer being able to pump, and then their heart failed. Here's another one where we can actually see lung cancer. So this is small cell lung carcinoma that we are able to detect on the coronal CT images, as well as we can see it at autopsy as well. So the kind of black area is the area of the tumor. Here's another case study where we had a gunshot wound. So remember that when a bullet comes out of a gun, it's very, very hot. So what happens is it actually, if it's shot at close range, it actually signifies cauterization. So here we can see that there's a definite injury here. And then at autopsy, when we did the histopathologic findings, we can actually see how the bullet cauterized the liver tissue as it passed through. Here's another example of a CTA of a patient with multiple injuries after a traumatic event. We can see that they have a broken wrist and a broken ankle, but the really valuable here, the thing here is usually you don't die from a broken bone. What we're really worried about, and why we never pick up a fracture and kind of manipulate it, is if one of those bone fragments is going to rupture a vessel. So on this one, you can actually see the vessel ruptures caused by the broken bones. All right, so here's another one where we're looking at the circle of Willis. This particular patient was a 52-year-old female found in the bushes under circumstances that suggested sexual assault. However, a post-mortem examination excluded any violent cause of death. So when we just found the body, they were treating it like a homicide and possibly a sexual assault. Then once we did the post-mortem CT, we were able to see that this was actually a brain bleed, and it wasn't likely to be caused by a sexual assault or even by trauma. It was actually just a ruptured aneurysm that caused that patient to pass out in the bushes. And then you can see here's the really, really large aneurysm. Remember, an aneurysm is just kind of like a vessel that blew up like a balloon. When it blows up like a balloon, that's when we can treat it. When that balloon pops, it's no longer treatable. So you can see that there's actually a little hole here on the bottom left. where you can see that that was actually ruptured. And then the one on the right, this is the tissue sample where we actually put it under the microscope and are able to see the changes in the wall of the vessel. So you can actually see that there is a little bit of manipulation in the wall. There's this discontinuity here, or this kind of break in the structure, which also shows that there was a rupture in that vessel. Here's another one. This is a 41-year-old male patient that came with chest pain and back pain, went to the hospital basically 2 times in a row and was discharged home. And then they went home and passed away pretty quickly the day after. So the postmortem examination showed that they actually had a ruptured aorta. So whenever there's a dissection in the aorta, again, it's just like an aneurysm. So it kind of blows up. And then when it bursts, that's almost always fatal almost immediately. So we can see that there is tissue, the fluid in the tissue, and usually the aorta is going to sit right in front of the vertebral column. It's really deep because those are those high pressure vessels, and it's the largest artery in the body. So when we see it, it's just kind of like a perfect circle right in front of it. And we don't see any perfect circles. We see lots of this kind of branching material of fluid, and it's hard to tell. So here we can see the dissection. A dissection is when your body actually makes kind of a wall that diverts blood from the vessel to a different area. So it kind of splits it into 2. And then what happens is now there's only blood in half of that area maybe. And so the other area can become necrotic or it can fail. And then here are the tissue findings as well. This is a 75-year-old male who came from pain in the inguinal area, which is just kind of your deep, deep belly button area, and really bad lower back pain. This was caused by a huge abdominal aortic aneurysm. So remember, the aorta goes all the way from the abdomen up and over to the heart. So there's thoracic aortic aneurysm, which I showed you on the last slide. This is abdominal aortic aneurysm, and it usually presents as unexplained, intense abdomen pain. And we can see here again, we're looking for this nice circumscribed circle in front of the vertebrae, and we don't see that. We can see that it just kind of extends outwards. It's hard to tell where it ends. The contrast, the lighter area, is highlighting the vessel. And this one showed that they had a pretty massive aneurysm. So the fact that this just kind of feathers out into the tissue, this is that maximum intensity projection where we're able to delete just the vessels and look at that. So we should see something that looks kind of like a worm or kind of like a snake. And the fact that we see all of these little windings shows that that contrast is leaking out and that vessel is no longer intact. This is another case study of a 56-year-old male who didn't have any previous treatment and just died unexpectedly in the street. So they really didn't have anything to go off of. The forensic autopsy revealed areas of myocardial necrosis, which means that part of the heart muscle was actually dead. And if it died, it means that there wasn't oxygenated tissue or oxygenated blood supplied to that tissue. So it's usually indicative of trauma or indicative of a heart attack. So what they found is that the necrosis was about 9 centimeters by 3 centimeters inside. That's a huge part of the heart. And there was a double rupture of the posterior wall. So you can see that there's ruptures here and there's ruptures here. Those ruptures correspond with where the contrast leaked out in the chest. So we should see the contrast stay in the ventricle. It comes here from the aorta. It's going to hit the atrium and then into the ventricle. And we can see it leaking here into that pericardial space and that pericardial sac. So that one was most likely the event of, caused by trauma. So that's not something that would normally happen. All right, so now moving on to MRI. It's more recent that we use MRI in forensics. CT has been really good. And again, with CT, when they're post-mortem, we're not as worried about radiation dose. So we didn't really explore MRI all that much. Then we got curious. So MRI is great for neuro. We know that it's really good for brain. It's really good for nerves. It's really good for tendons and ligaments and connective tissues. So we said, well, if it gives all that information in a live patient, why don't we try it in a non-live patient? Because a lot of times, especially if we're looking like severed spinal cord or a brain injury, we're going to be looking at those areas anyways. So we particularly use it for musculoskeletal, cardiovascular, and angiographic applications. We'll also use it for forensic imaging of the living. So like pediatric forensics, we are really worried about CT dose. And we're trying to image gently, as ASRT would call it. And so we would use MRI instead of CT to reduce the dose, because patients can still live long enough for that radiation-induced cancer to show up. So if it's a child that survived strangulation or a patient that was severely malnourished. So there was a story in the Riverside County area of a family of about 14 children, the Turpins. This is all publicly available, so it's not HIPAA, but the Turpins that were, the parents were malnourishing the children, and they were the victims of severe abuse. So what we could do is use MRIs to actually estimate their age. The children were much older than they looked because of this severe malnourishment for many, many years of their life. The limitations of using MRI is all based on water molecules in your body. And when we apply a magnetic field, a strong magnetic field, and radio frequencies, we can cause those magnetic poles of the water to flip. And when they flip, that's when we get our images. Well, if 80% of your body is water and then it degrades as you decompose, then MRI is not as valuable. And you can actually see this in the image on the right. We can see that the brain has physically shrunk, and it has now been replaced with air in the skull. And so as it shrinks, it kind of smushes it down. And so we're not able to really see all of the different sutures and all of the different anatomy. So there is quite a bit of limitation in MRI. Virtual autopsy. So it looks very similar to this. I was actually at the Museum of Science in Boston, and they have a very similar thing just like this, where you can kind of look at anatomy on a giant iPad, and it's very interactive and multiple people can look at it. So this helps. Virtual autopsy connects radiology with forensic medicine. It's a non-invasive approach, so it doesn't harm the body or tamper with forensic evidence, which is why it's become so useful. We can create 3D models that can be easily accessed and relayed to a computer. So multiple people in different geographical regions can all view the same material and give input, and then make decisions by analyzing that data. It's currently the standard procedure for forensic investigations, and it's emerging worldwide as taking place of conventional autopsy in facilities that have the resources. So again, it really takes quite a bit of funding. There may not be funding for imaging at the coroner's office, but a lot of places will pair with teaching institutions like the UC system to do their imaging for coroner's offices. It speeds up the decision-making process because the imaging really is so quick. We also don't have to worry about preparing our patient, running labs, making sure that their kidney function's good, telling them to take a deep breath and hold it. We're not limited by any of that. So we can get these imaging exams done really quickly. It is observer dependent. So if the radiologist or the pathologist or the cardiologist, whoever's involved in kind of reading the results of the study, if they're not trained specific in forensics, then it can be very limited. But it does allow for objective data archiving. So we can apply artificial intelligence, which is huge right now. We can apply it to all of these cases and then make better analyses of the autopsy data. This is also really useful in cultures and situations where conventional autopsy is not tolerated. So some faiths do not believe in autopsy. They believe that it would be desecrating the remains and it may impact the ability of the soul to continue on into the afterlife. For religious reasons, even family members just rejecting kind of the idea of cutting up their family member doesn't sound appealing to them, or it doesn't sound like something that they want to consent to, because there has to be a consent unless there is criminal allegations. So this allows us to kind of do those autopsies without necessarily having to meet all of those demands. All right, so here is another video showing what virtual autopsy looks like.
This is unbelievable. I've never seen anything like this before. We've seen x-rays, we've seen CT scans, but this is a 3D version of this woman.
The original CT scans Jerry made of the woman have been loaded into a piece of groundbreaking software. It allows for a virtual autopsy of the body, unlocking the secrets contained within without making a single incision.
Normally, I'm looking at sections or regions of the body, but this thing lets me see the entire body, and I can spin it and roll it and go into it and come out of it. This is a way that I have never been able to look at a body before.
With just a swipe of a screen, it can move between multiple layers of the body, digitally stripping back skin, revealing internal organs, and showing the skeleton beneath.
If we had examined her, let's say in 2000, we would not have had the capability with the CT and the MR, and this wonderful table would not have been there.
Yeah, right. We'd have x-rays.
We just have plain x-rays.
Right. Typically in an archaeological situation, you never really know how someone died, the cause and manner of death. Based on what's left is usually the skeleton, unless they have a bullet hole or an arrowhead in them. Here we can see clearly the cause and manner of this woman's death with smallpox.
Well, the surface, you can see all these smallpox lesions on her head, on her neck, on her chest, down into her thigh area, and even down into her feet.
And then on her heel and on the pad of her foot and the ball of her foot.
Typically with smallpox, the rash really initiates in the mouth and your oral cavity. So they become very sore. You have lesions inside your mouth, and then it becomes a full-blown skin lesions in a centrifugal pattern. And that means predominantly in the limbs, but also on the trunks. And quite often it was documented that they would have exceptional fever, immune response, and then a significant drop in blood pressure, which indicates some type of organ failure.
I would have only expected lesions on the surface. But if we look inside her skull, this is her brain. Now, covering the brain, there's this tissue that's very dense. It's kind of the consistency of canvas, and that's to protect the brain. And it's called the dura. And there are lesions on the dura. What makes this really unusual is that I don't think anyone has ever imaged an individual with smallpox, looked inside, and here we've got evidence that the lesions are in fact inside.
It's amazing. It's like we have a map of how smallpox colonized the human body. That's a first. It's a medical first.
The woman's body was so well preserved, the smallpox that killed her remains clearly visible, something Jerry and Scott wouldn't usually get to see from skeletal remains.
So I love that video because it really shows how they can manipulate the data, and all of that is made possible by the 3D rendering on the CT scanner, which is pretty commonplace now on most CT scanners. They have those 3D rendering capabilities, which is really great. Okay, so moving on, one of the other ways that medical imaging has really advanced the study of a pathology has been CTE, or chronic traumatic encephalopathy. This got a lot of traction when Junior Seau, the San Diego Chargers football player, died by suicide. And then on autopsy, they revealed that his brain was very different than a normal brain. And then years later, Aaron Hernandez was convicted of, well, he wasn't convicted, he was charged with murder. He was being held, and then he pled guilty, and he died by suicide in prison. So when they also did an autopsy, his family actually requested that they did an autopsy. And there's a good documentary on Netflix for this one as well, but they requested it. They found that he had CTE. So with Junior Seau and with Aaron Hernandez, while there was an indication that they might have a disease caused by cumulative head trauma, there wasn't confirmation of it until after that person died. In 2017, we had our first diagnosis of CTE in a living person, which is exactly what we want to do because we want to prevent it before it ends up in homicide or suicide. So this was really, really helpful. And you can see here's a normal brain on the left. What happens with advanced CTE is your brain actually shrinks. The gray matter shrinks faster than the white matter, and your ventricles get much, much larger. So you can see that the ventricle, this is actually Aaron Hernandez's brain, which they donated to science to be studied. You can see that the ventricles are much larger, and you can see that this gray matter is becoming a lot more prominent than the white matter. And then we are able to stage it post-mortem, but now we can also do this using MRI ante-mortem. We also use another medical imaging modality, which is helpful, particularly for CTE, and that is nuclear medicine. So these are some nuclear medicine scans of a control brain, which would be like a normal non-athlete brain, and then NFL players who have confirmed concussions in the past. CTE is specific to multiple concussions without really a good stage of healing in between. And we can see that there's hot spots or areas that uptook the radioactive isotope. So that's an indication of pathology near the thalamus and the amygdala. And you can see how different all of these brains are from the actual control. So nuclear medicine is another way that we're using ante-mortem studies to diagnose CTE. So I said that I would talk about 9/11. So following the 9/11 attacks, more than 200 military and federal personnel assisted in identifying the remains and conducting forensic investigations of the deaths that occurred at the Pentagon. The investigations occurred at Dover Air Force Base in Delaware, and they used radiographic analysis as a key step in that investigation and victim identification. So we could look at dental records. We did whole body radiographs of remains that range from intact bodies to body fragments, which helped process and identify those remains, which gives a lot of closure to the families. And the radiographs helped establish the presence of certain body parts, personal effects, and other materials in the specimens. So even things just as simple as in the person's pockets, they were able to identify that particular patient by doing radiographic imaging. It's also useful in aging victims. So I'll talk about bone density scans in a little bit. The benefits of these types of studies is that it could replace autopsy. We actually have a higher yield of diagnoses. We also know that elder abuse and child abuse, unfortunately, are common. And if we are able to do the imaging ahead of time, then we can do interventions in order to remove those people from those traumatic situations. Here's another example of the minimally invasive post-mortem CT, MRI, and CT guided biopsies that showed that we had a higher diagnostic yield, and then the implications for patient care, how we can use these to better our outcomes when it comes to diagnostic performance in ante-mortem and post-mortem imaging. DEXA scans or bone density scans, the dual energy absorption absorptiometry, X-ray absorptiometry. We can do density scans. They're not super specific and it's not being used all that much, but if we find only skeletal remains and we don't know the age of the remains based on like the size of the femurs and the humeri, then we can do a bone density scan to estimate the age of range. But they're still saying we should use this cautiously in anthropologic context because there are so many different factors. If bones are in a wet environment, they degrade differently. If bones are in a dry environment, they degrade differently. So DEXA isn't very specific yet, but it is still being studied. So there are limitations of, just kind of as a summary, there are some limitations. This is still an emerging subspecialty. It's not recognized by the ART as a post-secondary pathway. So we really don't have a good structured system as to what constitutes clinical competency and didactic competency. So we still need intensive research. We need standardization. Anybody who's practicing in this field, it's really kind of on the job, learning as you go, making it up as you go with very little instruction. We need guidelines. We need specific training, especially for forensic radiologists. For technologists, if you're interested in this field, you absolutely need CT and you most likely need MRI. And then you need interdisciplinary education. So in higher education, that's my background, I'm a teacher. In higher education, one of our main focuses in the last 10 years was bringing professions together while they're training. Because what used to happen is radiology would train and nurses would train and physical therapists would train and speech pathology would train. And then they go on the job and we don't necessarily know each other's jobs. So we don't know how to interact with each other very well. So now what we've been doing is we've been getting nursing students and speech language students and radiology students together, working together as students so that they're better prepared to work together after. So if we can get some of that interdisciplinary education between forensics and medical imaging now as students, then they're better able to work together after they graduate. We also have a lot of death data limitations. Death data is reported at state level, the county and the state, and we don't necessarily have a federal database of death data. And once we can get that and get some tracking and get AI on top of it, then we can build our analysis based on that data, but we've got to figure out how to collect it first. So those are the limitations of forensic radiology. Those are the applications of it. And hopefully this is a little bit of a introduction for you. I usually get a lot of people that are really, really interested in it. And the more interest that builds, the more likely we are to actually build some programs and be able to share this part of our profession with the rest of the world. So who has questions? Okay.
Yeah, I have a question actually.
Sure.
So when you're injecting like that contrast in these autopsy studies, I know like usually if it like you're doing it on a regular person, the contrast has to be expelled out of the body somehow. Is this the same process like if you're doing it post-mortem and stuff, or does it just stay in the body the entire time?
Great question. So when we inject contrast, it gets filtered through our kidneys and then we eliminate it via our GU tract. Because the patient's cardiovascular system isn't working, it stays in the cardiovascular system, and that system, while it's pumping in, it's also vacuuming it out. It's kind of like dialysis for the dead. So it's moved in and then moved right back out just like a tunnel. Great question.
Professor B, I have a question. Do you think there will ever be a time when virtual autopsy will take over regular autopsy that's done nowadays?
I think that there is, as soon as technology and the field and the profession and all of the education catches up to it, I think there's a really good chance of that. It will never replace it. So very much like AI will never replace a radiologist, AI can give us really good information about qualitative analyses, the numbers. We can read it, we can estimate tissue density based on CT number. What it can't do is look at the entire picture and put together what's going on in the pancreas, what's going on in the liver, what's going on in the bowels. So I think that that's where we still kind of need some of those other areas. We still need the histotechnology and the cytotechnology, but it's only going to add to the data. And the more information we have, the better choices we can make based on it.
I had a question.
Sure.
So for the CTs, when these bodies are brought in body bags, are they done at special facilities that is only dealt with dead people, or is it after hours? Because I can imagine patients don't want to sit in the waiting room and see a body bag.
And infection control, right?
Yeah.
So post-mortem, there are different infection control practices. These are usually done at dedicated facilities. Every once in a while, they will have contracts. So like at UCLA, where we scanned the mummy, it was done early in the morning in a dedicated room that was then closed for the rest of that day. So every once in a while, they'll do it in those, but it's going to be a lot more, it's like way more than a terminal clean. There's going to be different levels of infection control practices. So dedicated facilities are more likely, but because we don't necessarily have funding for those things, they'll contract with like teaching hospitals usually, and they'll use different infection control practices.
Okay.
Mm-hmm.
I was going to ask a question, Kristin. For anybody who's in school that would be interested in getting into this now, what would kind of be the pathway for them? I mean, if there's no official program at the moment.
Definitely get certified in CT. Go to school for CT. Highly recommend going through a structured program for CT. I know there are other things available out there, but nothing kind of replaces that structured program with clinical and didactic together. And then reach out to your local forensics and find out if their lab has any type of medical imaging that's a part of it. So the coroner's office is a great place to start. Or if you have like a forensic pediatrics unit in the hospital, that would be a good place to start because they have really good partnerships that are already in place. But definitely get CT. You know, CT is invaluable anyways. It makes up 36% of our radiation dose for a reason because it's really valuable and it's very highly utilized. And in this particular field, it's really a must.
Thank you so much. And as I'm studying sonography, so is there a place for ultrasound in postmortem or anything antemortem with any forensics, do you think?
The literature is very, very minimal in that area. So I don't know if there's a future for it, but as of right now, the literature just pretty much brushes over it as not even an option, but you could get involved in research in that area. And maybe if you go back for your master's, that could be part of your master's thesis.
I have a question. Would there ever be a thought that maybe another organization would qualify technologists for this? Because it seems like CT and MRI licensure is the ART's domain, but maybe a subsection that's not necessarily, because there's no radiation safety involved and things like that. But I think that's maybe what sounds like to me that's maybe hanging that up is it's not maybe in the right place. Does that make sense, that question?
Yeah, absolutely. So could we have like a forensics organization or law enforcement organization? Could they do effective training for a technologist that would only be for postmortem? I think that's definitely a great idea because again, it's not the radiation safety. It really is kind of a more of an on-the-job acceptable. And I would imagine that in states, those 8 states that don't have good licensure laws, that this is probably happening more often and you can get hands-on experience in that area. So maybe looking at non-licensure states, yeah, it's a good idea. Definitely a good idea. It would make it more available and more accessible to kind of the general use. Yeah. You all have great questions. Really good questions tonight. I've never gotten this good of questions, so I'm happy. Any other questions? I do want to be respectful of your time because I could talk about this for hours and hours. My students know me. I love to talk, but I do want to be respectful of your time because I know that you do not have much of it as a radiology or a sonography student. So any other last minute questions?
You said that this is part 2 of your presentation.
Mm-hmm.
Are you going to have another like part 1 presentation soon?
So mostly the part 2 is just updating it. So I added the chronic traumatic encephalography because we've now had advances in that particular pathology. Part 1 was just an abridged version of this. So I'm sure the next time you see me, I will have a part 3 with all of the updates. I do try to, on Fridays, I do a literature search of forensic and medical imaging every Friday, and I look for new articles. Very rarely are there new ones, but whenever there is a new one, I try to implement it into the presentation. So there will definitely be other versions of this, but not much different yet. Any other questions? All right, so I'm going to go ahead and give it back to Samantha and Michelle.